With so much in the air, I am doing something I never thought I would do, which is having to really consider how legislation and policy will affect the trajectory of my life, and balancing my passion for obstetrics and gynecology with the realities of thinking about where I want to end up and if I want to be near family or if I want to pursue my career. I think it's all very difficult right now.
In states where abortions are banned, residents will not be able to get those skills. And we don't know what the impact of that will be on even medical students choosing to go into OB-GYN residency or where people will be applying. And we just really don't know how medical students and residents are going to navigate it.
I know of faculty who are leaving programs because they absolutely cannot be forced to provide suboptimal care to patients. So we're going to see, I believe, OB-GYN faculty and providers leaving restrictive states. And then I think we're going to see that many fewer residents who graduate from these programs will want to stay in these states, and they'll leave as well. And so we might find ourselves in a situation with more people being forced to continue pregnancies, higher birth rates, higher morbidity, higher mortality in the setting of not enough OB-GYNs, with OB-GYNs who are leaving the states. So I think we're going to see some really devastating outcomes.
We just heard the voices of current medical students, program directors, and OB-GYN specialists who are considering options for the future of OB-GYN training in light of the recent Supreme Court decision that overturned the legal precedents set by Roe v. Wade. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA and the JAMA Network. This JAMA Clinical Reviews podcast represents a collection of important conversations that JAMA editor Dr. Linda Brubaker and JAMA Internal Medicine editor Dr. Deborah Grady had with specialists in the OB-GYN community around the topic of OB-GYN training programs in the U.S. They specifically focused on the effects that the new abortion legislation may have on medical education. Abortion restrictions challenge the core tenets of physician practice. Such restrictions also place barriers to high-quality educational experiences for medical students, as well as medical services for patients. According to the American Public Health Association, even before the Dobbs versus Jackson decision, the 14 states with the most restrictive abortion laws had among the worst maternal and child health outcomes in the country. We wanted to first hear from the perspectives of medical students as they contemplate new uncertainty associated with the way obstetrics and gynecology will be taught and practiced in the future. JAMA Associate Editor Dr. Linda Brubaker spoke with Kendra Lujan, Margot Zimmerman, and Hannah Wien, 3 second-year medical students from Boston University that co-lead BU's chapter of Medical Students for Choice.
When I entered medical school, I knew in my heart that I would want to go into OB-GYN, and as much as I tried to keep an open mind, something just kept calling me back.
Hannah, your thoughts about how the Dobbs decision has affected the location of where you think you might go to residency, regardless of the field you go into. Has it affected which states you would consider?
Absolutely. I would say that it has really changed my outlook on my career and my future. I have to also balance the fact that if I want to pursue OB-GYN, I might have to do a residency in a state where the education would not be provided in the state. Either I might have to travel out of state and find another program to take me in temporarily, or I have to wait to do like a fellowship after my residency ends. Do I want to be torn between multiple locations as I train and want to settle down? And that's a calculus that a lot of residents and students are making right now.
Kendra, what are your thoughts about your residency state choices? Has your list narrowed following the Dobbs decision?
My plan was to go back home to California for residency, but I know that California is notoriously competitive, and with the Dobbs decision, it just got a little bit more competitive. And so that is something that scares me, that I might not be able to match back home. But I definitely would want to go to a state where I have reproductive autonomy.
Margot, I'm sure you have thoughts on this as well. I'd love to hear them.
So a lot like Kendra and Hannah mentioned, absolutely my preferences would be to apply within states that have preserved training as well as preserved rights for abortion care. The hope was for me to stay in Boston with my residency being in OBGYN. That being said, as was mentioned, the difficulty in applying into OBGYN, especially in Boston, which has not only some of the best programs, but also which is as progressive as it is, the competitiveness of it by itself will be a lot higher. The added issue is the fact that I'm not sure that I want to even consider a state where my own rights are going to be impinged, because ultimately I know that if I were to go to a state and if I were to become pregnant and decide that it was neither the time nor place, I know that I want to feel protected. I want to feel protected by the people around me, by the state, by the hospital system that I'm working for, which does mean that to some degree, not only is my list of residency programs that I'll be applying to going to be massively restricted, the competitiveness of it is going to go a lot higher. And so I have had to start considering the possibility about dual applying or even potentially looking into other options. My hope is to just go into OBGYN and get really lucky and manage to get accepted into a program in a state also that continues to preserve women's rights. But it's been a difficult shift in priorities where I have to consider my own rights as well as finally just the competitiveness of it. So I'm currently struggling a little bit with the dilemma of what to do, but I think in the end, I will likely be looking into programs that exist within states that still preserve my rights as a woman.
The struggle can be heart-wrenching for many students considering OBGYN training in determining whether or where they will train. And this struggle for training is something we've experienced in the U.S. before. In 1993, a group of medical students responding to almost a complete deficit of abortion training available in medical schools started Medical Students for Choice. This nonprofit, founded by Dr. Jody Steinauer, works to ensure that medical students are educated about all aspects of reproductive health care, including abortion. In order to gain a historical perspective on this issue, JAMA Associate Editor Dr. Linda Brubaker spoke to founding member Dr. Steinauer about starting Medical Students for Choice, as well as her current role as the director of the Ryan Residency Training Program.
I started medical school in 1992 at UCSF, and we were just going along in our anatomy physiology classes. And two things happened that really caused an awakening in medical students across the country. One is that many of us, the estimate is about 10,000 medical students, received a mailing from an anti-abortion organization that was a pamphlet of very offensive cartoons about an abortionist. And that arrived in people's boxes, I believe, at the end of November, early December of my first year. And then in January, Dr. David Gunn, who was an abortion doctor in Florida, was murdered. And so those events caused me and my friends at UCSF and lots of other medical students around the country to begin thinking about abortion in the context of the profession of medicine. And we at UCSF started organizing some panels. I remember one was we invited doctors in our community who did abortions as part of their practice to sit on a panel. It was called Who Will Do Abortions? And we had them talk about why they felt abortion was really important for them. We had lectures about medication abortion, which was just beginning. And I started talking to some local reporters, and they said, oh, we've heard from our reporter colleagues that there are other students who are doing the same thing. I have a colleague in Southern California who said that the students at USC and UCLA are organizing around the same topic. And I heard there were students in DC and New York doing similar work. And so I took the summer between my first and second year, went and spent the summer at the National Abortion Federation, just talking on the phone on a regular old landline. And that just blossomed into a huge movement of medical students that is now worldwide. But we just founded this organization. And the whole premise then and now is that every medical student must learn about abortion. They will see people who need abortions, and they must learn about it. It is part of normal healthcare. And that led to the ACGME, the Accreditation Council for Graduate Medical Education, in 1995, passing a requirement that all OBGYN programs should have routine abortion training. And so that's sort of the beginning of when it became a requirement in my specialty and has led to a lot of the work that's been done since. The reason this is so important is because it is our professional requirement, our obligation as OBGYNs to be able to empty a uterus for a pregnant person to save their life. So we have to make sure that our OBGYN residents graduate with the skills to empty a uterus. They also need to be able to provide miscarriage care, what we often call pregnancy loss care, and be able to provide abortions for patients. So the ACGME requirement was both because this was a real crisis and too few programs training people, and also a real recognition that this is part of our specialty's obligation to patients.
Could you expand a little bit on how that relates to the residency program training, the Ryan residency training program?
After the ACGME passed the requirement, and then it was enacted in 1996, you can imagine that this caused some stress for residency program directors throughout the country, because they said, well, wait a second, now I have to make sure that my residents have routine training in abortion care, but at my hospital, we don't provide abortion care, or I don't have a relationship with a clinic in my community where abortions are provided. And so this led to a need for support for these programs. And Dr. Uta Landi founded the Ryan program in 1999 to do just that, to provide support for residency program leaders and chairs to figure out ways to make sure they could provide abortion care and make sure their residents could be trained in abortion care. And so this support includes things like, what kind of ultrasound do you need to order? What does evidence-based pregnancy loss care look like? What is the dose of medication abortion? How do you access medication abortion tablets? What kind of nurses and other staff do you need to provide care? So some of it was very technical care level advice and support. And some of it was, how do we provide the best training? So very education-based support. And initially, until about 5 years ago, programs would apply to become Ryan programs. And when they were ready, when they had the champion faculty and the leadership support in place, they could then apply for a grant program through the Ryan program. And we would provide some support for them financially to help pay for staff, buy ultrasound machines, sometimes to provide support for the faculty, to really develop an abortion care program. And as of now, we've supported 109 programs in the US and Canada to integrate abortion training into their residency training program.
So how does the Ryan residency program function for OBGYN education programs when currently many states are rolling back abortion laws, in some cases mid-program? Dr. Linda Brubaker spoke with Dr. Aileen Garapi, a board-certified obstetrician and gynecologist who specializes in complex family planning at Weill Cornell Medicine. Dr. Garapi reflects on her own training experiences and what she thinks may be the future for medical students going into the field of obstetrics and gynecology. Dr. Brubaker and Garapi discuss some of the methodologies used in OBGYN training, and they use a few technical terms during this discussion. PPROM is the preterm premature rupture of membranes. The abbreviation D&E is used to indicate the medical procedure, dilation, and evacuation.
When I was in training in obstetrics and gynecology, there was no one to teach me how to do second trimester abortions. And I tried during residency to get that training through electives, etc., and it just wasn't available. The ACGME requirements for abortion training weren't that robust when I was in training. And I was a generalist OBGYN for 3 years in Philadelphia, and it was heartbreaking to take care of women who came in and had PPROM at 19 weeks, and our only option was to do a labor induction. And a patient said to me, "What do you mean I have to go through labor for a baby that I can't take home? Can't you put me to sleep and take care of this and wake me up when it's all over?" And that real story and my inability to take care of those patients pushed me into doing family planning fellowship. And it's been the most rewarding decision that I've made because I get to be with people in really vulnerable moments and help them to deal with that in a compassionate, safe, evidence-based way.
Is there enough support so that all the OBGYN residents in training who want to seek abortion training now can meet their training requirements in the United States?
I think we are in a completely new landscape with the Dobbs decision. It has completely hamstrung residency programs, just like for patients, for physicians in training, where you live will completely dictate whether or not you have access to this training. Just like where women live will dictate whether or not they have access to essential health care.
So is your institution considering offering opportunities for out-of-state residents to receive abortion healthcare training to come to your institution for training that they can't get at their institution?
That is absolutely a national conversation and one that Weill Cornell is considering. It is setting up an infrastructure that wasn't previously needed. Despite the early leak of the Supreme Court document about Dobbs, I don't think people were really prepared for this. The Dobbs decision upended the last 50 years of medical training and abortion access in the United States. We're still figuring out what the repercussions of that are. The Ryan program, which is a program that highlights and helps to ensure that OBGYN residents get comprehensive training in abortion and contraception, but the number of residents at a particular hospital or academic center is matched up with what the patient volume is. Each institution is committed to training the residents that they have there and making sure that there is enough volume to gain these surgical skills. And so not every program in an access state would be able to partner with one in a restricted state without affecting the training of their own trainees. But I think that movement to bring trainees from restricted states to access states is something that we'll be working on at Weill Cornell and that people are currently working on across the country.
In your conversations with program directors nationally, do you anticipate that there will be some volume shifts so that the current number of abortions may stay the same, but shift in where they're done, being done in access states as opposed to restricted states?
We know that a certain portion of women who are denied abortion will go on to carry the pregnancy and parent. We know that from the turnaway study, that of patients who presented for abortion care and in this study were at the gestational age limit for abortion care and were turned away, that the vast majority of those patients didn't go elsewhere, that they instead continued their pregnancy, also that they did not choose adoption. They parented those children. And so women in low access or no access states, it's not clear that they'll even seek abortion in another state. So I think what we'll see is potentially overall the abortion numbers going down because more women will be forced to carry their pregnancies.
We understand that residents have always had the opportunity to not fully participate in abortion training during residency. If a resident chooses to not fully participate, what clinical limitations might they face when they handle patients with early pregnancy loss or complication?
In my experience in training residents for the last 17 years, people who choose not to do the full participation do not have the same surgical skills as those who do. We know that with surgical skills, volume matters, and doing the same procedure many times helps to build muscle memory and helps us to recognize when something feels unusual or is unusual. And so in my experience, the residents who have chosen not to participate fully in performing first and second trimester abortions do not have the same surgical skills. And that's problematic if you're, say, a maternal fetal medicine subspecialist and on the head of labor and delivery in a small rural hospital, and a patient comes in hemorrhaging PPROM at 20 weeks, and the quickest and the safest way to end that pregnancy and to save her life is to do a D&E. It is a skill set that if you don't have, you will not be able to care for that patient, which could be catastrophic.
Let's talk a little bit about the residents who are in training programs now in states that have become restricted states. So when they selected their program, they anticipated that they would receive this training. they're now unable to receive that training in their home institution in that state. What options will they have to acquire the training?
My heart breaks for those residents in Wisconsin and Ohio and Texas and on and on. There will be training opportunities once they graduate. There are ways to get abortion training in the United States outside of residency. But obstetrician gynecologists, their training should be comprehensive enough, complete, by having access to all of those skills that they need during training. To have to go above and beyond after training, that's a heavy load to bear. Ultimately, I went to do a fellowship in order to get that training. The fellowship in family planning has graduated 400 fellows who are now across the United States, and being able to provide that D&E training to the residents where they have gone on to have their academic appointments, or if residents rotate at other clinics like Planned Parenthood. And so that dissemination of those skills is happening for residents now, maybe where it didn't happen 20 years ago, but that's only in states where there is access.
Medical students who are in the process now of beginning to put their thoughts together for their match lists. Match day will be March 17th, 2023. And we don't know what we're going to see, how many people will be going into Ob-Gyn, or whether the restriction will affect where they apply and the number of applications for access states will go up. What's your prediction for match day of 2023?
I think that we might see a dip in overall applications to OBGYN this year. I think that for some people, having your ability to take care of patients be dictated by legislature, like that doesn't happen in cardiology. That doesn't happen in internal medicine or psychiatry. That level of interference, I think, will cause some people to not do OBGYN. And I think it will also embolden some to make sure that they get training in an access state. I would expect that applications to restricted states, or at least ranking of some of those restricted states, would be impacted. I know that program directors in those restricted states are doing their best to train their residents. They're looking at simulation modeling. They're looking at away rotations in access states, but it's just not clear that they're going to be able to meet those needs. And residency is only 4 years. If it takes a year for a program to deal with this Dobbs decision, or even 2 years, then that's half of someone's residency that could be affected if they're in a restricted state.
Looking forward 3, 4, 5 years, do you think we'll see redistribution of obstetrician gynecologists in the United States based on this legal interference?
I do. And that breaks my heart that women might not have the same access to all the other services that OBGYNs provide. I think there's a moral injury that happens for OBGYNs and abortion care, knowing that 1 in 4 women will have an abortion at some point in their life, and to not be able to use your full skill set, to not be able to take care of people and to practice medicine in the way that patients need, creates a moral injury for the physician who came to this specialty in order to give women and pregnancy capable people the highest level of care. And I think that we will see that graduated residents and OBGYNs will be leaving restricted states.
Dr. Garapi talked about residents who are in programs where access to abortion training may shift mid-residency. This is something increasingly relevant for Dr. Charisse Loader, who is an assistant professor of obstetrics and gynecology at the University of Michigan and director of the Clinical Family Planning Services in the Division of Gynecology. JAMA Internal Medicine Deputy Editor, Dr. Deborah Grady, discusses the impact of the Supreme Court Dobbs decision on training in Dr. Loader's state of Michigan, where abortion laws may change after the November 8th midterm elections. They discuss how these legal changes complicate the ability of OBGYN residents to gain access to the training they need and want to provide to their patients.
Michigan is an interesting place to be practicing medicine right now. We had protections for abortion care in place with the Roe v. Wade decision. However, there is a historical law on the books in Michigan from 1931 that does make abortion or ending a pregnancy illegal in almost all cases except for endangerment of the pregnant person's life. With the Dobbs decision, that 1931 law was enforceable again. And so we're faced with the concern that we would not be able to offer abortion care in the state of Michigan.
Can you give us some perspective on how training in obstetrics and gynecology and medical education is shifting or potentially will shift post-Dobbs?
One concern that I've heard from students, residents, and faculty alike is that the treatment of miscarriage is very similar to abortion care itself. And there are concerns that a physician who is treating a patient with a miscarriage could be misconstrued to be performing abortion care and could be prosecuted in some way. And so I think it's important to recognize that other types of care are being affected by the Dobbs decision, and people are approaching even miscarriage care differently because of the highly restricted environment of abortion care right now.
Is there a clear standard of care for when a pregnant person's life is in danger due to miscarriage? Because, in many states, that's one of the situations in which abortion can be performed legally. Is there a clear standard of care here?
So much of the legal language describes this endangerment of maternal health, although this is not how we typically train in the provision of medical care. We know that there's a spectrum of endangerment of someone's life, and it's hard to know if I intervene at a certain time point, if a court or judge would agree that that was suggestive enough that there was an endangerment of my patient's life to intervene in terms of abortion care. It's really unclear as a healthcare provider in making that decision. I know what I think is best for my patient and what I think will help them have the most successful outcome and healthy life. But I don't know what a court or judge will say about that or if they would agree about that. And that's really unsettling as a healthcare provider. The idea that I would have to wait until my patient was sick enough to intervene is really disturbing when I know that I have a safe and an effective treatment that's available to them.
I just want to ask you if there's anything else that you think it would be important to mention to our listeners, particularly regarding training.
I'm committed to training our students and our residents in other programs also. I think it's really important that we train people who are providing the standard of care and training people to gain competency and skills in abortion care. We know that if we don't train those people, then patients will suffer. And we know that the patients who are most likely to suffer are those who are at the margins of our society. And so I fear for people who are already experiencing disparities in reproductive health care, those people will have even more disparate care.
Dr. Loader has concerns about clinicians providing substandard care. Being in the position of having to provide substandard care can result in moral distress for clinicians, particularly when that substandard care disproportionately affects patients and communities that have been historically marginalized in healthcare settings. Dr. Steinauer and medical students Hannah Wien and Kendra Lujan talk about the impact of amplifying health inequities experienced by historically marginalized groups.
There are already huge inequities, and we know that some people, it's estimated that only 1/3 of the people needing these abortions in these states will be able to actually access them. And we know that those people will be more likely to be well-resourced, insured, white, native-born people in the United States, people who are English-speaking. And so when there's inequities, it causes even worse moral distress for the nurses, doctors, and learners who are taking care of those patients. We already knew that there were differences in who can access abortion. It's not like these restrictions came out of the blue. These are all in states that already had very extreme restrictions in the care provided, mandatory waiting periods, parental consent laws, mandatory ultrasound viewings. So it's something the Ob-Gyn community at large and the residency training community has already been doing a lot of teaching about and a lot of support for advocacy and to try to change the laws. And so I think this is just basically building on that to an extreme that none of us ever thought we would see.
In states where pregnant people are dying at much higher rates than around the country. Individuals who otherwise may have gotten an abortion before severe pregnancy complications or delivery complications occurred are now having to go through pregnancies, potentially unwanted pregnancies, and experiencing maternal mortality or morbidity. So that is very concerning.
I do fear a lot for the most vulnerable patient populations. For the first time in our lives, we would have to make a decision between what's best for the patient and our own livelihood. So I think patients might suffer as a result of these restrictions.
The future of OB-GYN training in the U.S. seems to be at an inflection point. Fewer opportunities for OB-GYN education because of the Dobbs ruling means that there is less access to quality reproductive healthcare overall in the U.S. Uncertainty about new legislation is pervasive among OB-GYN training departments, and the effect of this uncertainty means that clinicians may leave the field or never enter the field to begin with. And that means the health of patients around the U.S. may be adversely affected. This episode was produced by Shelley Steffens at the JAMA Network. The multimedia team here also includes Elena Guobata, Jesse McQuarters, Daniel Morrow, Audrey Foreman, Lisa Harden, and Mary Lynn Ferkaluk. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.